Good afternoon and welcome to our panel conversation, Understanding the Challenges of Caregiving in the LGBTQ Community. My name is Juliana Valencia and I'm a caregiver specialist with Fairfax Area Agency on Aging. Today's conversation is based on the experiences and unique challenges of aging and caregiving in the LGBTQ community. While there are no reliable Census Bureau statistics on the number of lesbian, gay, bisexual, transgender, and queer older adults living in the United States, SAGE, which is the country's largest and oldest organization dedicated to improving the lives of LGBT older adults through advocacy and services, has reported that based on research, there are around 3 million LGBT older adults, and this number is expected to grow around 7 million by 2030. And through research, we have come to know that LGBT older adults are twice as likely to be single and live alone, 4 times less likely to have children, far more likely than their heterosexual peers to have faced discrimination, social stigma, and the effects of prejudice, and therefore more likely to face poverty and homelessness, and to have poor physical and mental health. Our panel today are experts who have a wide range of experience working and advocating for the LGBTQ community, and they will provide all kinds of insights on this subject. Now, very quickly, I want to let you know that you will have the opportunity to submit your questions once my conversations has ended, and I will let you know when we get to that time. A few housekeeping rules before I introduce our panelists today. Today's presentation is going to be recorded, and our recording will be sent out to you by early next week. Also, at the end of the presentation, there will be a quick survey. Please help us by giving us your feedback. Now it is my pleasure to introduce Kathy Gerson. Kathy's background is in clinical home-based hospice and palliative nursing. She was named one of Loudoun County's 40 under 40 for her LGBTQ inclusive hospice operation, where she was the administrator, which focused on service area seniors and connecting our LGBTQ older adults to community resources. Now, Kathy now works as a senior nurse consultant in an effort to modernize the Veteran Administration's healthcare software to better serve our nation's veterans. Our next panelist is Alan Dinsmore. Alan was a staff member of Senator Frank Church on the United States Senate Special Committee on Aging. He worked as the Associate Director for Advocacy at the American Foundation for the Blind and was a board member of the National Council on the Aging. He was also a representative for the American Foundation for the Blind to National Leadership Council of Aging Organizations. He was a member of the Alexandria Commission on Aging and chair in the Transportation Committee. Alan served in the board of directors at Home in Alexandria and is currently serving as a co-chair at the Home in Alexandria Program Committee. And my next panelist is Karen McPhail. Karen is the managing director of Elementals LLC and founder director of Aging Rainbows. She is a professional care manager with over 30 years of experience in the healthcare industry. She is a registered nurse and holds a master's degree in nursing, and she is also a certified dementia care practitioner. She has been working since 2001 as a private healthcare consultant, care advisor, and care manager in the DC metro area. Her specialty is managing complex care needs and providing concierge-style care management for private clients. As a care manager and aging life care professional, she has been educated in the various fields of human services, including case management, psychology, mental health, nursing, pediatrics, and gerontology. Now, I want to welcome all of you and thank you for being here today. I would like to start this conversation with Karen. Karen, could you talk about Aging Rainbows and why did you feel compelled to start this organization?
Of course. Well, Aging Rainbows for me grew out of many years of personal experiences and professional clinical experience. And it really came to a head for me one afternoon when I was advocating for a transgender patient. And to make a long story bearable, basically this client had been functioning well at home, had an injury and needed, before we knew it, skilled nursing rehab temporarily. The rehab center really did not have a good understanding of how to provide inclusive care for LGBT older adults. And this individual was going to be placed in a gender inappropriate room. And it took me about 2 hours of advocating and trying to really shelter my client from this to finally have her placed in an appropriate room with a female roommate. And it did all end positively for this patient. You know, at the end, you know, her and her roommate exchanged numbers, they hugged. It was very positive, and it was also positive for the rehab center, but it really sparked in me some frustration, and it really was, for me, a call to action. It said to me, there's time, enough of this. I need to do more than what I'm doing, because if this is happening for one individual, it's happening for numerous individuals. So basically, I came home, and what you see on the Aging Rainbows website was created, except for maybe the organizations that are associated with Aging Rainbows and current information, but everything else I created, believe it or not, in about 30 minutes. I sat in my office and just started typing and pouring out all these ideas and all the things that I ideally wanted to achieve with Aging Rainbows. So it really grew very quickly after I had the website up in about 45 minutes and did the articles of incorporation and everything else. And I got the logo from my daughter. I started then spreading the word and sent a very nice email to about, I don't know, 1,200 people that I know well in healthcare in a variety of areas. And I was very pleased and kind of waited with bated breath by my computer to see who would respond. And really, it grew very quickly. People were very interested and had the same concerns, that they were the same things as me. So basically, you know, we've created a group of like-minded individuals across sort of the care continuum in other areas, and we're fostering inclusive care, fostering inclusive service providers, educating people out in the care and service area communities, and trying to give also individuals better access to a variety of individuals that they need to interface with as an older adult. Elder care attorneys, making sure they understand how to meet the needs appropriately of LGBT older adults, making sure senior centers are welcoming and offer programs that are enriching to individuals in this group, making sure care communities know what are good considerations. How do they support inclusive care? How does it become something that is part of what they do as an organization? And how do they create safe, welcoming spaces where people don't feel marginalized, where people feel safe aging and feel part of a community? So really, Aging Rainbows was, again, a labor of love for me, and it's something that's grown. I'm happy that people are benefiting from the information we provide, the services, and that we're making good, positive changes out in the community and across the country. So.
Well, thank you thank you so much. That, you know, I love that passion that it's in, you know, that you are expressing yourself with, because it definitely takes a lot of dedication and determination to be able to create an organization that is making such a big difference in our community. So thank you for doing that and for helping create a more inclusive community at all. You know, that's important. So my next question is for Kathy. Kathy, could you talk about your work experience in hospice and the health disparities that you have seen within the LGBTQ older adults and caregiver?
Certainly. My experience in hospice and mostly in the post-acute space, which means care that people receive out in the community after a hospitalization or at a doctor's order that they can get out in the community that doesn't require the level of care of being in the hospital. You see a lot of disparities within the LGBTQ community in that there's a lot more challenges around chronic conditions. And the reason for this has been, sadly, a lifelong learned fear of going to the doctor and getting that preventative care that we all think of as a normal thing that everybody has access to, and everybody can get that doctor's visit and that preventative care and those follow-up visits that really give you a lot of health education teaching. So when we in hospice would see LGBTQ patients come in, overwhelmingly we'd find that there were a lot of newly discovered, I should say, chronic conditions that had not been well managed or not been well attended to for a very long time. We come to an assumption as a society and even as healthcare providers in a very heteronormative sense that everybody, what could possibly be the challenges that an LGBTQ senior would have, because what would be the connection between, gender identity or sexual orientation? What does that have to do with them going to see a primary care physician? And it's part of that mindset that we as healthcare providers really have to work towards to be really actively aware of. One of my first experiences, and I say that because it probably wasn't my first experience, I just didn't know. When I was a hospice nurse years and years ago, I was caring for an older woman who was in hospice and at the end of life. And we were making visits to her several times a week just to manage her symptoms, make sure she had what she needed. And there was always her sister there. And that's who she had introduced us to, was her sister. And her sister was very attentive and was living there to help care for her. And come to find out, it wasn't her sister. This was her life partner. This was before SCOTUS several years ago. So this was someone who had been her life partner for quite some time. And as I started to absorb that, and that was kind of similar to Karen, that was when it started to go off for me. How many times have I been in somebody's house as a hospice nurse where they have spent so much time dialing back who they are and who these relationships are? I noticed that there were pictures missing. There were ways that they had camouflaged their own living space for fear that this service coming in, what they didn't know what that could mean if we had felt one way or the other about it. We gave this woman excellent care, and when she passed away, we received this really beautiful letter, and sad, from her partner, who said that hospice care was the first time that they had felt truly comfortable being open about who they were and what their relationship was, and that we were able to honor that as part of our bereavement services. But over the years, it really had me thinking how sad that somebody would have to wait until hospice to feel like they could be open about their relationship. And for me, that's where my real passion about ensuring that there was inclusivity around LGBTQ patients in end-of-life care, which really spurred my work in creating an LGBTQ inclusive hospice.
Wow, that's a very powerful story. And what a difference that made, I bet, for them, that they were able to experience that, to be themselves at the end of one of their lives. So it does definitely say a lot about our healthcare system. And we'll definitely get back to that, because I definitely want to learn more. Thank you for sharing that story. So my next question is going to go to Alan. Alan, could you talk about your advocacy work and some of the initiatives and programs that different counties in Northern Virginia have implemented to create a more inclusive and equitable community? And I know that this is kind of a very complex question, but if you can kind of summarize it or give us what you think will help us understand what has been done to create a more inclusive and equitable community, that would be great.
Well, I think understanding that when we say diversity in our community, we often have said a lot more than even we understand. If you look at advertising, for example, people will talk about, well, this is specifically aimed at the Hispanic community. Well, look at the Hispanic community that I know. It's a very diverse community. Put an overlay on that of LGBTQ, and you have other things that you're careful and sensitive about. Family involvement, for example, is very different from group to group. My partner in retirement has been a Washington tour guide for quite a few years until that business just collapsed with COVID. But one of the mainstays of the tour guide business were Black family reunions. They would come into Washington for sightseeing with a 55 passenger bus with every seat sold. And he said, you stay with these people for 2 or 3 days and you understand close bonds. He said, it's not something as a white guy from Michigan that I'm really used to. And you begin to be immersed in it and you begin to understand more. So I think partly that immersion, and even in our own communities, we tend to think that we know someone if we say, oh, they're part of the LGBTQ community. Well, you don't know me. I'm 77 years old. I grew up at a time that was very, very different. When I was trying to grapple with sexuality at 13, there was nothing. Right now, you could make the argument sometimes that there's too much, but I think I would prefer to go with too much rather than having absolutely no asset at all to go to. But if you do look at across the board where people have lived, what their education is, what they're used to, you'll find many, many different facets. And I'm sure you've seen this in your own work. It just helps to talk to somebody a little bit and make them comfortable. And then you begin to learn things about their lives that are very important with respect to the work that we do in trying to develop programming that works. I have one anecdote from our friends in Sage in New York. When they opened their first day facility in Queens, this was for people to drop in during the day, the standard kinds of things that they do. There was a very substantial African-American population in this particular section of Queens. Opened the doors. Well, they talked to a couple of people, the neighbor said, and they said, well, you know, we all have childcare responsibilities. Not like some of you white folks down in the downtown area where you're widely separated from your families. These are our kids. We have to take care of them during the day. So they figured that one out and changed it around. But it's that whole question of diversity that it's an asset in the sense that it can be a set of wonderful and sometimes totally unexpected experiences. And sometimes too, it can really send you up the wrong road if your assumptions about somebody is wrong just based on what the color is or where they came from.
That's absolutely true. So have you noticed, at least in this area, we have a quite diverse population, and like you said, I mean, a diverse Hispanic population, a diverse LGBTQ community. Have you noticed efforts from different counties to create a more inclusive community in their programming? For example, I'm wondering if you have found support groups that are specifically for LGBTQ caregivers, or for that matter, older adults, or I don't know, I think you used to serve in the Commission on Aging. Have you noticed any type of initiatives that will promote that?
Well, the Commission on Aging, which is the advisory group to the City Office on Aging and Disability Services, has been working on that. And one way you start is to try to make the place as welcoming as possible. At least you put a sign out for people. So they have been working to get SAGE certification now, and they work their way through the first 3 levels, and they hope to platinum in this so that they can begin displaying this in the materials that they distribute. And I think that's an important first step. The other thing that I'm aware of is that your own Fairfax County, I believe Fairfax County is the contractor for all long-term care ombudsman services in Northern Virginia, is it?
Mhm. Yeah.
That they are, I think, a platinum certified provider by SAGE, and that's very important. The more people can see some of these things when they pick up your brochure, the better the chances are that they will come forward and say, hey, I need to do something. Do you know something about this? Or I would like to do something. Can you find me some help so that I can start with somebody else?
Hmm. It is amazing, right? Just one small step will make such a huge difference. Yeah.
And I think
Thank
Alan
you.
makes a really excellent point too about you don't know me. You know, I think we have obviously come light years over the last several decades in terms of public awareness, but there is still an expected stereotype, if you will, of what an LGBTQ senior should look like. So people assume, and of course I'm making a general statement here, but there's an assumption that you would be able to identify somebody on site based on characteristics or who knows what. When we have so much in, you know, when you see today when they have jewelry commercials with a lesbian couple, or you see movies coming out that have more LGBTQ storylines and plot lines, that's great. But are we seeing more, as Alan is saying, in the advertisements, are we seeing older couples in LGBTQ relationships, so that those are the signals that this is an inclusive place, that this is, you know, something that that our agency is familiar with and knows how to deal with.
That's a good point.
Yeah,
Yeah.
I agree completely. If I can add, a lot of times when I go into care communities or speak with service providers, that's one of the biggest pieces that I hate to say I'm not surprised by, but people do tend to, unfortunately, stereotype. And that's a big part of what we talk about in terms of educating care communities on communication. It's not just having, you know, a safe space sign. It's not just having a flag outside. It's about creating a whole culture that is welcoming, a whole culture that does not marginalize, a whole culture that creates this whole feeling that someone gets me. And that starts having an initial communication in a meaningful way. You know, I speak to a lot of people and they say to me, we have no issues. We treat everyone the same.
I'm glad you brought that up.
Really? Well, you can provide the same level of services. That's great, but we never want to treat everyone the same, because then we're marginalizing. And then I usually start back with history. And as I start to educate people on history and the Stonewall generation and where people have come and where things have been, then they start to slowly have that moment, that aha moment in their eyes. And they finally start to get it. Why you can't treat people the same. Why you cannot dismiss the past, because the past is meaningful, and how you engage people and let them know you understand and be able to form trust. So
I like that. And actually, I have a question for you. So, you know, it's interesting because I definitely want to get back to that. You have brought up a lot of good points, and but I want to get to this question. So last year, AARP published a survey on LGBT older adults and caregivers. And the survey showed that 76% of LGBTQ adults were concerned about having adequate family and social support. Now, why is it important to understand the concepts of family of origin versus family of choice? And how does that impact caregiving in the LGBTQ community?
is that a question for me?
That's a question for you, Karen.
Well, I think it's important for people to realize, again, looking back at history, you know, it was only 1973 when being gay was not considered a mental health issue. So when you look back, you have a lot of people who do not have families of origin. You have a lot of people who do not have the support that other older adults have, and you know, as they grow older. So I think it's important for people to realize, you know, families of origin are not always going to be there for our generation or current generation of LGBT older adults. Now, this is going to change over time, I would hope. I'm very hopeful for that. But many of my patients have families of origin, or have families or chosen families, and they've developed families over the years. But oftentimes they're of similar ages, so they can't always provide support, you know, especially when a healthcare situation develops. So one thing that I always am taking into consideration as I'm looking at, you know, families of origin and chosen families with LGBT older adults is the fact that I may need to help in engaging more families or connections rather for my patients, because they're going to have less support oftentimes. And as they get older, less access to forming and fostering those relationships, you know, as time goes on. So when I have an LGBT older adult client, I always talk to them about sort of their family dynamics, their support services, and start to, you know, of course, develop a little bit of trust and understanding along the way so that I can help foster and help them to feel comfortable, and perhaps reaching out and branching out a little bit more to have additional support through new connections if they don't have, you know, that many chosen family members or connections anymore, and if they are estranged from family members of the past. So it really is, for LGBT older adults, it is a challenge for a lot of the individuals that I work with, because they just don't have the support that you would see in some of our older adult population. And right now with COVID, it's even more concerning because, you know, some of them can't access some of the online programs because maybe they aren't, you know, great with using some of the new programs and platforms, and they don't have individuals they can call upon to help with that. So at times I've been guiding some of my patients through that process because I want them to be able to have additional support and be able to continue to foster some relationships and support on a level that helps them, you know, and on their terms also. That they feel comfortable with. So it is a challenge. I know through Aging Rainbows also, we're trying our best to kind of foster, you know, mechanisms for people to continue to have support and find ways to form sort of their network, so that if they do have a care challenge, we can come together and form a care calendar with individuals they feel comfortable with, to provide them with support and socialization and other aspects. So it is a challenge, but it's something I think if we all consider positive ways to foster connections, we can kind of break some of these dysfunctional cycles and help people not to feel lonely. As we know, in older adults in general, loneliness is a national epidemic. You know, we have more loneliness than ever, and now with COVID, we even more so. So I think, you know, if we can be creative in fostering relationships and helping again to create safe mechanisms for people to feel comfortable taking a chance and moving forward and embracing a little change and doing that, we can make positive differences in this area.
Thank you for that insightful answer. It definitely, I think we have to step out of our own shoes to be able to see what our community needs. And sometimes it's difficult, because especially if you think about aging, and older adults already are very vulnerable, and plus you have to add everything else to that, and not having family makes it even worse. Absolutely. My next question. Sorry, go ahead.
Some of you are probably familiar with something called the Harvard Longitudinal Study. This is the oldest longitudinal study of aging in the country. It was started in 1937. I don't know whether it has an LGBTQ component to it. I kind of doubt it. but it has got every other component. And one of the things that I was thinking about, Karen, as you were making those comments, is their director said, you know what the most important indicator of successful aging is? And by that, I mean getting through a lot of these problems and not being defeated, and adjusting as best you can. The biggest indicator is a family friendship network. And it could be family, it could be friends, it could be a combination, but the stronger that is, the better off all of the people in the study have been.
Yeah, and that brings me to my next point, actually, and this question is for you, Alan, because you've done a lot of work in the advocacy arena. So from that perspective, I imagine you have a lot of knowledge of the different policies that may or may not support caregivers in the LGBTQ community. So we know that, as you mentioned, there is a lot of diversity, because many of them are going to rely on their family of choice, which a lot of the times are friends. And so what have you noticed are some of the challenges that family leave policies present to LGBTQ caregivers who are providing care for a loved one?
Well, the biggest challenge is they don't do a very good job of it. If you look at the definitions under the Family and Medical Leave Act, there is one major good piece, and that is if you have a civil union marriage, you are covered. But if you're just living with someone, as is the case with an awful lot of older people, or you have a situation where you need to take care of someone who is not a member of your immediate family, the kind of coverage, and this also presupposes that you're employed. So, we're talking about a large segment of our population who is now retired. So the Family and Medical Leave Act isn't going to do very much for them. So there is not a lot of support out there. And that's too bad, because with all of the effective advocacy our community has undertaken in so many new areas, this is one that we still have not recognized as a priority.
So let's say for different organizations, what would be a good way to create more inclusive policies to support caregivers from that perspective? Alan?
Well, some states, Virginia is not one of them, unfortunately, although we just have a new impressive omnibus package that affects the rights of people in our community. But some states have moved more aggressively than others. I think probably finding a member of the legislature, the House of Delegates, or the state Senate who is willing to look at this and possibly take it on, and that this is something that is a long-term project. But moving some of our advocacy hardware off in that direction probably be very helpful, because for everything that we've been saying, this is a major issue. You cannot, if you're a child, it's very difficult to gauge child to get support for taking care of someone who is, for example, not your father or mother. Let's say your adopted father or mother, or the person that you would rather call your father or your mother.
At a local level, do you think we can do that?
Well, on a local level, I mean, there are some good political organizations in Northern Virginia, and there are also Virginia-wide organizations too. I think it would be a good idea if for people who wanted to work on this is frankly, if you've got a connection to anybody on the board or to their executive director, write a letter and say, where is this on your agenda? That's one way to start it. And maybe a little more direct, saying, I don't know whether this is on your agenda, but it certainly should be. And I'd like to know if it's going to be, and if you need help putting it together, what can we provide?
Very good, thank you. So my next question is going to Kathy, and I'm sure you know this, but I'm going to say it in case some of us may not be aware. So research shows that LGBT older adults are significantly less likely to access medical services than their non-LGBTQ peers. So in your professional experience, have you come across this type of situation? And could you give us a little more insight into why do you think this is happening?
Certainly. As I said before, I think the access comes from a couple of things. First of all, you have to back it up a little bit. It's not necessarily due directly to LGBTQ status, but it's impacted. For instance, as Alan was saying, you have to be employed. If your LGBTQ status is impairing you from becoming employed because there are not policies in place that prevent that type of discrimination, then the kind of work that affords people health insurance, which is a whole nother conversation entirely, but those kinds of jobs may not be open to LGBTQ people. Therefore, they may not have that safety net of having that kind of coverage to be able to seek healthcare in the ways that a lot of people find very easy. So there's that piece as well. Well, let's say you have health insurance coverage, or you have a means of being able to access healthcare, through being in a metropolitan area or lots of choice or financial resources. But now you're coming into a situation where one of the most intimate relationships you have outside of your family is with your medical provider, because not only are we talking about physical exams, but we're talking about medical histories, which can be very touchy subjects, but which can be very important to be honest and transparent about in order to receive the level of care that you need for the outcome, for curative or for preventative or for whatever you need. A doctor or a nurse or any kind of a healthcare provider, social work, really needs to be able to have the whole picture so that they can be able to prescribe and diagnose and provide that level of care to people where they are. So if an LGBTQ person seeking care has encountered any kind of resistance or discrimination, or even a look, a face, a rolled eye, or anything like that, and of course I've unfortunately heard so many stories of that. It pushes people from seeking that care, or it makes them seek that care but keep certain information off limits. And so that's something that does bar LGBTQ community from getting that care, as I said before, particularly for chronic care. So we see a lot of patients in the LGBTQ community who have lots of cardiac conditions, who have things, diabetes, of course, all the regular diseases of aging and being a human being on the planet, but they aren't seeking that care in order to get that preventative or that care over time in order to slow those diseases from going on.
That's unfortunate, that's very unfortunate. I think we do have to do a lot of work in a lot of areas, really. So this is kind of a follow-up to what you were mentioning before. Could you talk about inclusive care at the end of life for LGBTQ older adults and their caregivers, and how different the process of accessing hospice services may be for this community versus their versus their heterosexual peers?
Certainly. Well, I'll come at the first part of that question from the position of healthcare in general, because I think accessing hospice is really no different than accessing any other kind of medical care when you're looking at just trying to find a service to meet a medical need that you have in the moment. And when we look at that, there are lots of ways that healthcare providers can show that inclusivity. And it comes from things like we were saying before about how the marketing looks, how the brochures look, putting things like your SAGE certifications, having LGBTQ couples and other representation in that material. But when it comes down to the clinical care, we're also seeing that you need to have the staff ready to have these conversations. People are embarrassed to ask, what are your pronouns? People feel uncomfortable. So as a clinician, finding the comfort in understanding that this is just part of a medical history. This is part of building a relationship with your patient and with your patient's family, to say, instead of, what's your husband's name or what's your wife's name, to start saying things like, do you have a partner? Do you have a significant other? Who do you call family, is a very inclusive thing to say, because it makes no assumptions. And I think that's where healthcare providers can really look to start rewiring the scripts that we learned in nursing school and in medical school, so that we can start having those conversations very naturally. And when we look at our agencies, having forms to fill out that don't just say male and female, they can have an option for non-binary. You can have the option to even indicate sexual orientation on there as well, which can be very helpful for future clinicians coming through, particularly in home care, who are relying on those assessments to kind of learn something about that patient before they go in. So I think doing that and being comfortable with your clients to be able to say, am I using the correct terms? Am I, I think by and large, the LGBTQ community is happy to see somebody have an interest in making sure they're doing it correctly and respectfully. And I think that's where we can go in terms of accessing hospice care and making sure that hospice care is inclusive. To me, the reason that I personally have been so passionate about hospice is that hospice is to me, and I hope to many others, a really special part of caregiving. It's a very special time in a person's life, in their family's life, to come in as a caregiver and to be able to educate and provide that comfort and calm about what's happening as this person transitions towards end of life. And when you're in this situation, you're in a very intimate moment with these families, because there's a lot of fear around what's happening, or what's happening with the patient, or how much time is left. And it's a lot of time when families are coming together. People are coming in from different places. And so sometimes that can bring turmoil. Sometimes that can bring excitement. Sometimes it can bring sadness. And so hospice in and of itself is already a very emotionally charged time that I wouldn't want a patient to feel like their identity, either through their sexual orientation or their gender identity, was an added layer of anxiety or concern in that. So in honoring that person's life journey, to me and to the healthcare providers that I worked with in our hospice, being able to provide inclusive hospice care was so much more important in those moments, to be able to fully honor who this person is as they go into end of life.
Wow. And I think that some of the practices that, actually most of the practices that you have mentioned, can be applied to other fields as well.
Of course, of course.
Yeah. So talking about that, my next question is actually for Karen. And this actually is related to what you were mentioning, Kathy. So Karen, a lot of social services organizations are including trauma-informed care in their approach to services. And I am interested to hear about the intersectionality between trauma-informed care and the experience of aging in the LGBTQ community.
Okay. I wanted to sort of give a little bit more content based on Kathy's last question, if that's okay first.
Yes, absolutely.
And then I'll get into this question, if that's okay with you. But because I think, I want to make sure people understand a couple of things. One thing that I've learned from being out in the field is that, people honestly don't oftentimes know what to do to provide inclusive services. What does that look like? People say to me, that's all great, but what do we do? So that's something that Aging Rainbows has done. And we've come up with inclusive care guidelines so that when we provide education free of charge to care community service providers, elder care attorneys, whomever is providing care, they understand, what does that look like? How do we communicate? We do scenarios with staff. We explain to them, what should your basic formalization look like? What should your standard intake process look like? Not just in terms of forms and gender neutral aspects, but also what are questions are important? Like, how do you approach things by saying perhaps, who's important to you? Or I see Kathy's here today. How is Kathy important to you? So just trying to help people understand, not just saying create welcoming, safe spaces, but what are the actual components down to how do I communicate? How do I make decor? How do I make sure my staff are not only educated now, but every year and every day? How do our programs provide for inclusivity? How do we make sure activities every month celebrate occasions for all people? So trying to take all of that and giving practical ways to change care communities is kind of something we're doing. So not to rebut to Kathy's, but if people are looking for options on how do we make that happen? Well, how do we make our forums work? We look at forums from a variety of individuals and service providers every day and give recommendations and other aspects. So I did want to rebut that. So I apologize if I got off my question, but it took more than 2 minutes. I didn't even answer mine. But trauma-informed care. Trauma-informed care for me, getting back to the question, I was like, what was the question? Oh no. For me, providing trauma-informed care is really a key to quality and a key to achieving positive long-term outcomes for clients. And for those people that are not familiar with what the concept of trauma-informed care is, it's a concept drawn from psychiatry. Ooh, sorry, thunder. That asserts that past experiences of trauma can have all sorts of impacts on current health. And so basically trauma-informed care shifts the focus from what's happening or what's wrong with you or what's going on clinically to what has happened to you. So a trauma-informed approach to care really acknowledges that healthcare organizations and care teams need to have a complete picture of a patient's life and their life care situations, both past, both present and past, in order to provide effective healthcare services and to be able to move people forward with sort of a healing and focus and care, if that makes sense. So really to begin, it's important for everyone to recognize that trauma is common. Almost every individual has probably had some sort of significant or serious trauma over the course of their lifetime, and understanding the potential paths, I think, for recovery are truly the core of sort of trauma-informed care and this whole discipline. So, many people don't realize that about a third of older adults served by our healthcare system have a backstory, a significant backstory. And this is especially significant for those in the LGBT older adult population who have a significant history of, at times, severe trauma that contributes to their overall health and their well-being. It inhibits them from accessing care. It leads to health challenges. And it directly intersects, I feel, with their experience as an aging individual. As I said before, it was only 1973 when being gay was no longer considered a psychiatric condition. So we see LGBT older adults who have had decades of trauma, past experiences of persecution, discrimination, family abandonment, isolation, decades of perhaps living in a fearful manner or being treated as if they have a mental illness. So this is all leading to mistrust, leading people to have significant post-traumatic stress reactions, I see clinically, when of course they have to access care as an older adult. I see individuals manifesting all of this past trauma through panic disorders and anxiety, that all of a sudden, everything starts to come to the surface when they think to themselves, I'm scared to access care. I've pushed it to the side, and good God, I need it now. I can't avoid it. I have to have it. And I see a lot of things start to come to the surface in terms of depression, self-neglect, isolation, and other aspects. So trauma-informed care for me assists people in these situations by providing sort of a basic framework for assessments and intervention. And not innovation, interventions. You know, although healthcare providers really through this approach aren't really expected to treat their patients' past trauma, they're expected to acknowledge it and to show an informed understanding of their trauma to help them move forward in a functional and positive way. So for me, adopting trauma-informed practices can improve patient engagement, treatment compliance, health outcomes, you know, less resistance to care, and really support and reduce, I think, reduce costs on the healthcare system and social service sectors, because you're not waiting. If you can get people to trust and access preventive care and form a relationship, you can stop things down the road. I see people in terms of, you know, undiagnosed hypertension and leading to kidney disease, and then we're on to dialysis or transplant, all because we were afraid to access care. We're afraid to get the education we need. So I've gone on a while. So to summarize, and I'm going to summarize, I swear, through a greater awareness really of the intersectionality between trauma-informed care and the history and experiences, I feel of LGBT adults, we can positively impact care outcomes. You know, we can break dysfunctional patterns and set sort of that groundwork for more functional practices and healthy habits and routines. So last comment. I encourage everyone to check out the U.S. Department of Health and Human Services, their substance abuse and mental health services website. They have guidelines on trauma-informed care. They review the steps of really how to become an informed trauma-informed care provider. We'll go over the definitions of trauma so that people understand really how to tap in and engage. What really a trauma-informed approach is in terms of realizing and recognizing and responding and resisting re-traumatization. That's a mouthful, but they will. And just going over all the principles. There's really 6 key principles. So we could go on, honestly, for hours about trauma-informed care. But the basics are, it really is a very important approach with LGBT.
One thing about that occurred to me, Karen, while you were talking, and that is with respect to trauma. And I'd be interested to know your opinion about this. I think one of the things that happens in the LGBTQ world is that trauma is a perfect storm. It sweeps a lot of things in. It simply overwhelms you. More specifically, I think that one of the things that research says is that it gives a person an intense feeling of shame. And this may be one of the reasons why people, one of the many reasons why people don't ask for the kind of care, because they're ashamed of themselves. They don't want to bring this up. And that is along with abandonment from significant people in your life, like your parents, who will tell you that they never want to speak to you again. You know, is it any wonder that people in our population have substance abuse problems and difficulty in that kind of assertion that is necessary to make this system work for you?
Wow, that's very insightful.
And it's yeah. I mean, people oftentimes, you know, have been able to sort of push some of those pieces under the rug, as you're saying, for a time period, and then things start to resurface. There's triggers that, and oftentimes people haven't dealt with those feelings. And as they're feeling more vulnerable and they're needing to access care and these feelings are coming out, they become overwhelmed by them and almost paralyzed. And I do see people self-medicating. I do. I see people, you know, one client of mine, I remember talking about patterns. I was trying to get to the root of some things, and I was like, wow, you know, so what do you do every evening? And every evening, I know he was drinking more than 2 glasses of wine, you know, just to try and put himself to sleep in his recliner. You know, because there was a lot going on, and some of his aging reminded him of his parents, and he wondered how they coped with their aging. because he never got to see them actually physically age and pass or be involved in supporting them. So I agree, Alan, there's a lot that emerges, and unfortunately, dysfunctional habits develop. And I think if we can give people an understanding that we get it, and give them a mechanism to bring these feelings out in a productive way and slowly start to work past some of how they feel in terms of shame, in terms of all those things, we can make a difference.
Talking about that, it's very sad to me that as people get older, they have to, all of this comes happening, and we have to realize that as we get older, we get more vulnerable. And so thinking in those terms, my next question is going to be for Alan. Sage stated that 48% of LGBT older adult couples experience adverse treatment when they are seeking senior housing, and transgender individuals experience higher rates of discrimination. Now, AARP has said that 1 in 3 LGBT adults are concerned that they will have to go back into the closet or hide their identity when they are seeking housing. So having that in mind, and with the passing of the Values Act this year, how likely are the LGBTQ older adults and caregivers to trust the system and access inclusive housing?
I think it's going to take a lot of work. And I think that one of the things that has to happen is, again, there are organizations in our community who need to take this on. When SSI was created, there was a tremendous outreach effort to tell people, you are qualified for this. Here's the information that we need from you. Otherwise, it would have just flowed right past them. And I think this is what is happening with some of the improvements in life. The people are still, for the reasons we just discussed, very reluctant to come forward, very reluctant to be assertive at the level that you need to be assertive in order to get your rights. Even when your rights are fairly well established, if you don't know about them, it's really not a right at all. So I think there is a problem, particularly for people in my age cohort who have been used to hiding much more than others for all of the reasons we've discussed, to get them to go in there and say, well, this is what the law says, and me and my partner should be in this facility, and you can't do this to us. This is asking a lot. So I think one thing we can all do too is to find ways in which we can use organizations to get that information out there, and to say, for example, if you think that this is an issue, here is an elder law attorney who knows something about this, who would be sensitive and will help you. So it's not going to go on automatic pilot. It's nice that it's there, but if it isn't getting out in the community, it doesn't exist.
It's going to take a while. And it's also going to take a while to educate the counterside, because the people may know, but the people who are managing housing programs may not be aware. So that's another aspect as well. So I want to be respectful of the time, and I want to make sure that we get to all the questions that we have from the audience. We actually have quite a bit of questions. So I'm going to ask my next question to Kathy, and then we're going to open the panel to our audience. So Kathy, last year, I read an article in the Washington Post about inclusive care and the fear of growing old in the LGBTQ community, or as an LGBTQ person. I specifically remember a passage that talked about Professor Kim Aquaviva. She wrote a book about about LGBT inclusive hospice and palliative care, and you probably have read that book. The passage described her experience in training health professionals, and she described a moment in which she asked a group of home care nurses whether they thought she was going to hell for being a lesbian. Then she tells them, it is okay if you do, but is the afterlife within your scope of practice? And so at the end of her presentation, a nurse approached her and said, I still think you're going to hell, but I'm going to stop telling patients that. that part really made me think a lot about our implicit bias. Could you talk about how our implicit bias influence our professional practice?
Well, you said we're short on time, so there's so much about implicit bias, and there seems to be a lot of talk about it. It seems to be a real buzzword, which I think is good because people are starting to become really aware of where our biases are. When I was in charge of a home health and hospice organization, what I used to tell my staff was, this is different than when I was a hospital nurse, because when I was a hospital nurse, it always felt like the patients were in my house. So the meals come at this time and the medications come at this time, and it was all very organized in that sense because you're in my house. But when we're in hospice and when we're in home health, we are in your house. And it is so important to remember that you're not there to really run the show. You're there to help enable people to see what their living situation is and work within, I don't want to say the boundaries, but you're working within what they have there in their home. And part of that is certainly not telling people where in the afterlife they are bound for, which unfortunately is something that I've had to deal with caregivers, thinking that they're doing you a favor by saying, well, this religious teaching is that, for a whole host of things, not just sexual orientation and gender identity. So it's really important that you understand that as a clinician, when you're in somebody's home, that you truly are a guest, and that you're there to provide a service and to be really clear about what that service is. And that doesn't mean that what you're doing has to be cold and clinical and, just this very straight edge reason that you're in there. But it means that I'm not in there to give you life advice. I'm not in there to make any judgments about what your home has or what your home doesn't have. My job is to come in and make recommendations about grab bars or things that could make your house safer, or ways that we can get caregiving or help in here, and then to understand where my boundaries are in terms of my interactions. And that being said, I think it's really important that we build relationships and rapport with our patients and our clients, and just as we were saying before, when we talk about implicit bias and we talk about what people assume, when I would go in as a nurse, people assumed that I was not a member of the LGBTQ community, which I am. And so, sometimes that was a really good entree to families to let them know that, what you see on the surface of people and the assumptions that you make about people and who they are and what their lives are like can, is just about as skin deep as it can be.
And it's important that we are aware of those implicit bias, because whether we like it or not, they are going to be there. And it's kind of the lens of how we look at the world. So at this point, I would like to invite our audience to submit their questions. And so, I do have a few questions that have been submitted, but if you have any more, please go ahead and send them in. So one of the questions is, what are your recommendations for social programs for this population? What are ways to make this population feel welcome or included? I'm going to ask this question to Karen, and I know Alan, you've talked about that. I don't know if, Karen, you can add a little bit more to it.
Well, that's been one piece also that we've been working on in terms of Aging Rainbows, and also as a clinician, I work on with my clients or my patients all the time. I think each individual is different, so you can't really do a cookie cutter approach to activities and socialization. Not everyone wants to play bingo, and so I try and make sure that when I'm talking to individuals, irrespective of who they are, that I'm kind of tapping into what they want. But what we try to do on Aging Rainbows is provide a variety of situations so that people can start collaborating online. They can be in safe chat rooms. They can have support groups online right now during COVID. We try and link people with also national programs. If you look on Aging Rainbows, there's a lot of information there, and we try and make it very easy. There's not a lot of hoops to jump through. We try and have things that support the DC metro area, but also a mechanism for people across the country to look and see organizations and programs for support. So, I think it's important right now during COVID, if you have a friend or a family member that is an LGBT older adult, checking in often. I try and find creative ways to do that. I have one person that we check in via Alexa, the Alexa check-in. Every morning I'll say, "Are you having your coffee, Jim?" And he's like, "Yes, I am, sugar-free creamer." And we laugh and chat for a few minutes and move on. But, you need to make sure that you're engaging people. And honestly, I said the one day to this client, "Do you enjoy these?" And he goes, "I love these. I live for these check-ins, coffee with Caregiver." So it doesn't have to be someone playing bingo every week, or maybe even attending a support group, because some people don't like support groups. They like more of a casual coffee talk. So I think it's just having a variety of things out there where people can easily access them. And I will encourage people to take a look on Aging Rainbows. It's easy to access these things because we try and put a variety under upcoming events and programs so that people can click and go, "Wow, that's sort of a national program where I can chat with other people from across the country." Sometimes it's nice to be able to say, "Listen, in Virginia, we're doing great, but my gosh, you're still having challenges." Everyone wants that sense of need. And sometimes as we grow older, we lose purpose. So finding a mechanism for socialization, but also purpose, I think is important. So I also have linked people to programs so that they can look for volunteer matches. There's a volunteer match app that's great for around here. I have one older gentleman, he has some constraints, but there's some things he could do. He's a very bright man, and he's doing some safe driving for transportation needs for individuals that are in need. And he's doing some safer volunteer work, and it's really helping him to feel like he's giving back during this time of COVID, even though he does have some limitations of what he can do. So there's ways to have people tap into organizations for online during COVID, for other things via a variety of platforms. But the whole point is to find what works for the individual. And to tap into helping people to have purpose, because that's what keeps us going every day. I hope that answers the question.
I think it does. And actually brings me to another point that I think is very important to make, and that is data. And this question is actually for Alan. Sorry, Alan. I am changing your name. Sorry about that. So somebody is asking, how do we produce more accurate data? We know that we don't really have a lot of data right now, and that is going to influence how we distribute budget, how we create programs. So what is your opinion about this question? How do we create more accurate data?
Well, I think we have some things to work with now. In the last census, we were finally able to include a question on same-sex couples. And the Hastings Law Center in California has done a lot of really excellent work in using that data as a jumping off point for the collection and analysis of other data. And one thing we should not ignore is that the statisticians in the world of social services and aging are always looking for something new. And there's one advantage that we have here. We're new. There's an area that you don't know very much about, and you can frankly do something, to be crass, for your credentials and your operation to do this. That's important to keep in mind. The final item is it's important to go global on this, but the fact of the matter is we need better data with respect to our local areas. For example, Alexandria's health department is very good. I think that they, along with other health departments, would be approachable on this question of collecting data with respect to COVID-19. We don't really have anything. We can just make guesses. And as a result, we can't really think about launching any kinds of programs that would be effective and even where we would do it. But so I think it's important to that, knowing that there are some assets that do exist, knowing that this is a new area and people like to work in new areas, and also where you can identify some local entities for local data collection, I think is also going to move us along.
Thank you. Let me ask you this. Do you have recommendations or of places where people can reach out? I know Karen has mentioned Aging Rainbows, and you, Karen, are doing a lot of advocacy and education. Are there any other organizations, and this question is for the three of you, that also provide resources and education for the LGBTQ community? Especially resources, I think, because sometimes when, as you said, this is a new area, and because it may be taken as a new area, as a new population, which is not, there is a limitation to the services that are available. So do you know of any resources that may be available for the LGBTQ older adults and caregivers? To all of you, sorry, to the three of you. I should have been more specific.
Yeah, I mean, I think, I work a lot with SAGE and SAGE Care. I'm actually a National Center for LGBT Aging Education Ambassador. And so I do a lot of work also educating out in the community and providing resources for individuals. But I think there's a lot of great resources. SAGE has a Healthy Aging Toolkit, which is a very good resource, and there's a lot online through the National Center. So I really encourage people to take a look at SAGE Care, look at SAGE and the National Resource Center. SAGE is the oldest advocacy organization. So I think, it's an exceptional resource, to be honest. There's a ton
and
of good
SAGE too also has a place on their website where they'll tell you what agencies in your area have partnered with them, so that you can know which places too, which different home and health agencies. I know Alzheimer's Association is always with them. So different groups like that can direct you which ones have been trained by SAGE.
Yeah, exactly. And that's something like for Aging Rainbows, when we do inclusive care training with organizations, their next step expectation is to become SAGE Care credentialed. So when they're working with us initially, we're sort of a building block to get them moving towards SAGE. What I'm trying to do is get people also to take the SAGE, the pledge, the long-term care and quality index pledge through SAGE to be an inclusive care provider also. So I think, if we have organizations such as Aging Rainbows and other clinicians kind of pushing in that direction, so that people are starting to credential more through SAGE Care and showing that credential on their website, it starts to become something where also it creates a natural safe space and then an expectation across long-term care. I always tell people that I feel, when you look at residents' rights, we're not always respecting residents' rights for LGBT older adults. We need to take a real good look at those. It's something that I've talked with even, Governor Northam's office a little bit here in Virginia about. I think they're gendered. I think we need to make some changes. And I think, people need to realize that in care communities, a lot of the things we're talking about really should be a mandate. They're part of the basics of all residents' rights, not just residents' rights for a few. So
I'd add here that I think if you're a reasonably good web searcher, you can really come up with a lot of unexpected things. For example, when I was looking at some of these questions with respect to the Family and Medical Leave Act, it dawned on me that there were some specific things that I really was pretty hazy on. So I just went to my search engine, checked out 3 or 4 things that I didn't know existed, of organizations that have an interest in what we talk about. For example, a very good source from the Association of Healthcare Journalists. A great place to place an article. The National Conference of State Legislatures has an excellent site that allows you to follow up on the number of states that have their own family and medical leave acts and what those require and what they will provide. So it's, if you're looking at a specific question sometimes, just pop it into your search engine and see what comes up. You may find some alliances there that you never thought of.
Yeah,
Wow.
if you put in over the web glbtnearme.org, you can find support organizations near you. To be honest, that's a great, search engine too, to take a look through.
So I am, you mentioned Karen, and I think I'm going to ask this question to the three of you. And we have 15 more minutes, so we still have a few more minutes to talk. This next question says, how would you treat the population different? What practical ways? And you mentioned this before, Karen. Do you want to start with it?
Well, in terms of how, I think do you mean in general? Do you mean in long-term care for adults?
This question brings me, and I think we talked about this before as well, and I had a conversation with someone about having this panel, and somebody says, well, don't expect me to treat people differently because I treat everybody the same way. And so, yes. And so within that, and this is for the three of you, it says, how would you treat the population different, the LGBTQ population different? What practical way?
What practical way? Well, I think, honestly, it kind of goes back to what I was saying earlier with, sort of trauma-informed care, I think is where I was talking about this. I think by acknowledging, I see my big piece that I see that's a real limitation in care communities and service providers in general is, people want to be helpful, but people are afraid to give individuals an invitation to be authentic with who they are. And I think oftentimes, for me, I feel that through really communicating and letting people know that you want to know them, really who they are, that in a care community, they don't have to be afraid to be the person they've always been, is the way that I think is important to treat people in the LGBT community. Creating and initially when you speak to someone, letting them know that you value the person they are, and then they should feel comfortable being able to talk with you about things that are important to them. I don't know if that makes sense. I don't know, Kathy, you're kind of nodding if you want to say something. But I think a lot of communication.
Mm-hmm.
Yeah, certainly, all that you've said, because I think that there's when people say, oh, I treat everybody the same. I know we talked about that, because that's the whole point, is that we're not treating you as if you're the same, because we're all so different. So I think it's really understanding and honoring those differences and honoring what makes people different, because people are products of the challenges that they've had or other things, and recognizing and honoring that and synthesizing all of that information into a treatment plan is how you can make sure that people are treated in a way that's going to have the best outcomes for them physically, emotionally, spiritually, and that's the way to go forward.
Yeah.
Mm-hmm. Alan, do you have any input?
I remember when I first started in the, I guess I could call it the community-based part of the things that we were talking about. I went with a colleague of mine, an invitation of a consortium of service providers in the metropolitan area. And this was one of the things that came up. Oh, we treat everyone the same. And I said, okay, well, let me try this. If you have a Valentine's Day party and you want people to put pictures of their Valentine up on the wall at your center, what's going to happen if a man wants to put up a picture of another man? Mm. And they all looked at me and I thought, boy, we have a long ways to go on this one.
Yeah, yeah. Thank you.
Alan, I'm surprised because one of the things I used to hear a while ago, and Karen, I'm sure you've heard this too, we don't have any LGBTQ seniors here.
Oh, yeah.
Right? And so when you said, I thought that's what you were going to say when he said, I'll put up a picture of my sweetheart, and they would say, that wouldn't happen here. There's nobody gay here. There's no LGBTQ people here. I've heard that a lot. And that goes back to these assumptions about stereotypes and yeah.
Yeah, and they think that they don't have any LGBT residents. This actually was asked, someone said this to me that I've known for years and that I've worked in healthcare with. And she said, I know we don't. And I said, you do. I don't think so. You do, because they're my patients. You really do. Really? Are they happy? And I'm like, no, they're miserable. You know why? Because they're hiding and they're marginalized.
That hurts.
Out in California who works for one of the large agencies who is Jewish, very forward, very identifiable Jewish name. And also, she does make a point when she talks to these agencies about programming of self-identifying. And so the response from one of the large Jewish agency providers was, well, we're Jewish. And she said, let me start again. Are you telling me that because you're Jewish, there's no LGBT people in your community? Because maybe you didn't hear me when I introduced myself. It was rather embarrassing for the other party. And they eventually did end up doing some good programming, but it was one of those assumptions that the person wasn't particularly mean or prejudiced. It's just that there's no Jews who are LGBT.
Yeah, I think it comes from the assumptions that we think, oh, we're going to recognize because we know how people look like, and that's not it. Yeah, and it's also sad because that means we haven't created a safe environment in which people are allowed to express who they are, and they have, and unfortunately, because of that environment, they have to hide who they are, because we haven't created that. So let me, this is my last question for Karen and Kathy. Somebody in the audience asked, given that many LGBT seniors have lived through the worst of the HIV/AIDS pandemic, have you seen any issues stemming from the experience come up during their care?
The thing that I would say has come up about that, and Alan, we touched on this just a little bit with the shame, is that at end of life, regardless of what your diagnosis is, your hospice diagnosis at end of life, some LGBTQ seniors are of the feeling that they deserve this, that they don't want to manage the pain because it's almost they're punishing themselves, that this is something they have brought on themselves, and so not in a big way, not in a big overhanging way, but they don't want to talk about pain management. They don't want to talk about a lot of that because there is some feeling of, and I know when we have had, we don't see a lot of HIV patients come through hospice anymore, which is a blessing, because people blessedly are not dying of that as they were. So that's something that I would say we have seen. But when you have all of the complements of a hospice care team, which includes social work and chaplain and nursing and all the other features, when you have a really great team in place, and when you have built that rapport with the family and with the patient of what your services are and what your, when you're inclusive, you don't even have to advertise that you're inclusive in that way, because it spreads and it's known. And so when you have that environment, people are more willing to talk, and we can help overcome issues like that and help to get people through those transitions at end of life in a comfortable way.
Yeah, I think, I would love to see, and I am getting to answering the question, but I would love to see more education and healthcare providers mandated in terms of LGBT care and in terms of care considerations, because I still see, you know, we refer a lot of patients to practitioners that we know will value and understand their care. But I still see, you know, I've had patients where, you know, they've gone into an urgent care and they've told them, you know, having this issue with the sore throat, blah, blah, blah. And they've disclosed that they are LGBT or they've gone with a partner and they've had serologies checked. Why? You know, we still see people not treated in an appropriate manner in healthcare situations and by clinicians, which then feeds on a lot of the fears of the past and perpetuates that continuing forward. So we've come very far, but I think we need to educate more so that people do feel more comfortable, because there is still, I think, some individuals are very hesitant because of, you know, the past in terms of the HIV and AIDS epidemic, you know, not being, you know, as a gay individual, that you're still treated at times differently. You know, so there are a lot of reminders still from that, and a lot of, I think, still hesitancy based on how things have happened in the past and triggers to people continuing to be hesitant based on that. People are not always treated during that time. You know, in terms of pain management and other aspects.
So this is my last question to Alan, as we are getting almost at the end of our presentation. Such an interesting conversation, and we could be here for hours, but we can't, unfortunately. So Alan, how has COVID-19 impacted the LGBTQ older adults in caregiving community? What have
well, as I said, we really don't have any good numbers on this, but we can make some assumptions that if you look particularly at healthcare status for older members of our community, particularly older members of our community who live near or below the poverty line, who don't have access to the kinds of healthcare, we know that they are going to be affected by this because of their vulnerability. You know, we also know, with respect to the trauma situation, the large numbers of members of our community who work in the service industries, in entertainment, in restaurants, in travel. I think there is an estimate that came out, and I wish I could remember the source now for this. In fact, it may have been Sage, that something like 40% of the people who've been employed of the population of the LGBTQ world work in those industries and have probably either lost their jobs or had a significant reduction that also just moves them more into the area of being very, very vulnerable for this infection, just as a result of the trauma and the stress, because that just follows from those kinds of experiences. So sum total on this, we don't have really good numbers, but we can make some assumptions, and they're not terribly encouraging.
Yeah, it's scary. At this point, I want to thank all of you for being here, especially to our panelists for giving us their time and your expertise. We are getting ready to wrap up, and as I mentioned before, there will be a brief survey as you signed out. Please take a moment to answer those questions and help us provide topics that you are interested in. Thank you again, Alan, Kathy, and Karen. Really, you have given us so much knowledge and education about this topic and the things that we need to do to create a more inclusive and welcoming environment. And thank you to our attendees who have submitted their questions. And I hope you have a wonderful evening. Thank you. Bye now.